The following podcast is a discussion between two experts in their fields of beauty and not meant to be taken as medical advice. Be sure to consult with your doctor if you have any medical inquiries.
I am honored to be joined by our esteemed dermatologist from South Carolina. This is Dr. Todd Schlesinger. He has a ginormous practice. He is super knowledgeable what we're going to be talking about, which is acne scars. He's written over 100 peer-reviewed publications. He's a Mohs surgeon, clinical investigator, trained at Cleveland Clinic, has a 3-office dermatology and dermatologic surgery practice. And his area of research is kind of all over these areas that we're going to be discussing, which is inflammatory dermatologic processes, cutaneous oncology, and cosmetic dermatology. We're going to be focusing on acne scars. I know we could talk about these things for a long time. So I'm super honored to be presenting our guest today, Dr. Todd Schlesinger. How are you doing today?
Very well, thank you. And that's some wonderful things you said. I appreciate that. But first and foremost, I'm a dermatologist, and excited about taking care of my patients.
Love it, love it. Okay, so super common thing that goes on is we're going to be just kind of jumping into this acne scars. So you're an expert in acne scars. I kind of want to know, before we get started talking about acne scars, let's get our audience just a little bit of background about it. So what are acne scars?
So acne scars are basically different depressions or problems with the skin that occur after the inflammation that occurs, when acne. And, it's a little bit of a complex cascade of how we get there, to an acne scar. But basically what you have is the core problem is inflammation. And when you have inflammation, you have a breakdown of collagen through, kind of the our innate immune system pathways. These are the pathways that occur when we're, first cut our skin. We're injured by injured, and we get bacteria, fungus, or yeast in our skin. We have inflammation. And so the first part of our immune system that will come up and attack that is our innate immune system. So what happens is you have breakdown of collagen, and, our body can never really restore collagen as well as it as well as it was when it was first made after inflammation. So when you have that breakdown of collagen from inflammation, you're talking about matrix metalloproteinases, things like that destroy collagen with inflammation. When that's rebuilt, when that collagen's rebuilt, it's never going to be as good as it was when it was new. And then you end up with, with various types of acne scars. So that's sort of like in a nutshell, process of how we get there.
Do you like the term acne scar? Because, when I think of a scar, you mentioned this a little bit earlier, it's like a scar is an abnormal healing process. When I think of a scar, sometimes we think of things like the Frankenstein jagged raised scar through here. I think of the term acne scar as kind of a misnomer. I think of an acne scar as being sort of I think a better term might be acne depression, because it seems like almost all the time we're trying to, create the void that's been left behind by these inflammatory processes you just described.
Yeah, and I think that's one way of looking at it. I mean, I feel like there is scar tissue there. So, while you do have an abnormality in the contour of the skin, in some cases, underneath that, underlying that, you have abnormal collagen deposition. And so by definition, I mean, that inflammation creates that inflammation creates abnormal collagen deposition, as that healing process occurs, after it's been broken down, your body creates collagen via a certain pathway, as we're born, or as our bodies develop, or as our skin develops. But when you destroy that collagen, whether it's by surgery or radiation or whatever it be, it just never can heal quite the same. Even with fillers, I mean, we're creating, inflammation with even fillers that we use, and that creates some type of abnormal deposition, which I would consider to be, definition of scar.
Okay. So for patients with acne, so I have some teenage daughters, they have acne. What percentage of patients are you going to say are going to have this abnormal process with developing acne scars? How common is this?
Statistically, I say it's actually fairly common. I don't know the guess of what the prevalence is, but I would just sort of say, most of my patients probably that have acne, end up without, permanent scarring. They might have erythema, which could be, treated as, they're scarring and maybe some scarring underneath that, but most of the time, they end up doing okay. It's when you get that inflammatory case. So it kind of would correlate in parallel with the prevalence of our more inflammatory cases of acne. So, I'm guessing probably 10 to 20% of my, of patients that have acne generally are going to have a more severe form that's going to result in scarring, probably at the minimum.
Okay, and let's define acne scarring just even a little further. So you mentioned inflammatory. So there's that post-inflammatory hyperpigmentation, or PIH, which is super common after a lot of things, but especially acne scarring. There's the depression aspect of scars that we kind of alluded to earlier. And then some patients, I think that's less common, at least I see, patients with raised scars from acne.
Right. So it's totally accurate. You can break down acne scars into sort of three broad categories. One is the hypertrophic scars, which you had mentioned is a change in the contour, sort of an elevated change. About 10 to 15% of the scars are that. And then you have, of course, your pigmented lesions where you just have flat, dark discoloration, which is a small percentage. But the vast majority of the scars that we see in clinic that we deal with on a day-to-day basis are atrophic acne scars. 85 to 90% of the things we deal with are atrophic. And then when you have atrophic scars, you can break those down into three more detailed categories, which a lot of people know is number one, you have ice pick scars, which are your small sort of depressions, less than 2 millimeters. You've got your rolling scars, which are more of a curve, more of a bowl, 4 to 5 millimeters generally in diameter. And then you have your sort of boxcar scars. Boxcar scars look just like that, like a straight down edges, and then a flat base, which would be kind of more consistent with just think of a shipping container, sort of that type of scar. And those can range anywhere between 1.5 and 4 millimeters, sort of on average. So most of the scars that we deal with that we can treat easily are the rolling scars, or that middle category. But certainly those are the most common ones we see.
Okay, so what have you used to try acne scars in the past? And then what are you doing now? And why did you switch?
Right. So I can say there's been a really interesting evolution in the treatment of acne scars. Of course, we have all kinds of things that we used to use. We might have used in excision of various kinds, depends on the type of scar, subcision, excision, punch excision, things like that have been around for a long time. Of course, we've used lasers in lighter skin, depending on what type of skin we have. We've used ablative, non-ablative, we use peels, all kinds of different things that we use. But I think we've evolved more into being more nuanced in how we treat our acne scars, and especially sort of as it relates toward skin type, especially, skin of color versus non-skin of color. So, with skin of, that is lighter color, of course, you can be a little bit more aggressive on using ablative lasers or maybe non-ablative fractional devices to sort of help us with our rolling acne scars. Box scars are tough. They really need surgery for the most part. Excisions, or resurfacing is great. But now we have the advent of all these new energy-based devices. So we've got radio frequency devices, high frequency ultrasound devices, and things that can sort of help us more, with those rolling scars, that they're still like the easiest ones to treat in general sense with microneedling. And then the advent of, fillers has sort of come along in the past few years, that we've been able to really learn how to use fillers better. And then combination therapy is really where it's at. And it really depends on the type of scar you're dealing with, the patient's penchant for downtime, and then the skin type. So really, those are the three main categories you sort of think about when, deciding how to treat a patient with, the scarring.
Okay, so let's kind of break this down a little further. We're going to kind of go into some nuances here. So a fair skin patient, we'll start with that. How effective do you think just pure ablative lasers? So for the audience, we'll kind of define ablative. Ablative lasers are those that take off that top layer. So you're going to kind of ablate layer after layer of skin until you get deeper into the depth of the skin to kind of improve that. Which ablative lasers have you tried, and which ones are you still using for your fair skin patients?
Yeah, so those are great questions and a great explanation of how you laid that out. We're still using a non-ablative fractional, such as a 1540 laser. Others might have a 1927 laser. When you're dealing with the acne scars that are more superficial, so they're not really too deep into the second layer down, not the epidermis, but the dermis, then that's a great place to use an ablative laser. An ablative laser is something like carbon dioxide laser, where you're really ablating the surface off, and the patient's going to have recovery and downtime. That's a really a 1 to 1.5 millimeter depth at the most that you're going to be going down. You go too much deeper and you're going to be creating more scarring from that, which we don't want to do. So if it's more shallow scars, And sometimes for, softening boxcar scars and for making ice pick scars more soft, but not completely ablating them and removing them because you can't all the way down, you have to do surgery. You can use the various lasers. When you have dermal scars, where you have the rolling scars that are a little bit deeper, the non-ablative, if you're talking lasers, non-ablative lasers would 1540, anything in that wavelength range. I mean, 1540 to 1927, all the way up to your erbium 2940 lasers. That's the range you're going to be working in the most. But mainly, if you're working in that non-ablative range, that 1540, that's where you're going to get a penetration deep into the dermis without ablating, without causing more scarring. And I like to talk to people and thinking about it as aerating a golf course. You see they make these little plugs in the golf course, and the goal is to let the grass grow in stronger when you make those plugs. That's kind of what you're doing with these non-ablative lasers, is you're making plugs that go into the dermis of the skin, but you don't ablate the surface. So, you can heal with healthier skin.
How many treatments do you need with a non-ablative laser and an ablative laser to get a difference where a patient's going to be happy? Can you do it in one treatment? Does it need 3 treatments? Does it need 5 treatments?
So the treatment number depends on the patient's ability to tolerate downtime and, of course, the depth of the scar. So for a carbon dioxide laser, typically that's a one-time treatment. You're doing a resurfacing of the scars. But many times what we're doing is you can really tune that laser. So you can really tune a carbon dioxide laser to be a more ablative or less. You can make a lot of changes in the settings. So sometimes you'll do a series of 5 treatments that are lighter ablative and get some nice results with that. And oftentimes with the non-ablative fraction of the 1540, all those different ones, those are typically at least 5 treatments. For acne scars, I'd err on the higher side, err on a little bit less power and a little bit more treatment time, a little bit more treatment number. Depending on the skin type. With lighter skin, you can tolerate a little bit, higher settings, and you can maybe do it in less treatments. But it's an evolution, and with acne, acne scars to sort of get them to turn around and to build that new collagen. And sometimes you need maintenance. Depends on the patient.
Okay, so we're going from lasers. We're going to kind of shift over to some of the other devices you mentioned. So radio frequency devices and with radio frequency needling. For the audience, again, these are devices with energy at the tips of the needle. You can go a little bit deeper than we've talked about. You can go 0.5 millimeter, 1 millimeter, 2 millimeters, 3 millimeters, 4 millimeters. What's been your experience with radio frequency devices? Is there a device of choice you like? And is there anything you're looking for in those?
There's not a device of choice. I haven't really jumped a lot into these devices because there's been so many coming out. I've focused mainly on laser devices and microneedling and fillers in my practice. I think with COVID, and I have an article in Practical Derm kind of coming about this in January, speaking about the changes that occurred during COVID. I was very careful about what devices I purchased during this time. The pandemic and the financial crisis that occurred, I think, for a lot of people, really, I think made a lot of people think about what they were buying. There's so many devices out there, and they're still as of yet unproven. I think that there's a substantial equivalence to a lot of these radio frequency devices there on the market. So I don't have like one I would pick. I know everybody's got their favorite device. But I feel like being real careful about what you buy is important, and really understanding it and what your return on investment is going to be. Because nowadays you can't just buy things that sit in the corner. You have to be very careful about what you buy. Because people are still recovering from. We're all busy back again, but we're still recovering. So I can't say I've jumped heavily into the RF microneedling. I think it would be great for patients who have darker skin. So if you're looking to treat acne scars in our darker skin patients, that's actually a nice thing to do, because you're still generating some heat. So you still run the risk of the post-inflammatory hyperpigmentation, which is also generally inflammation based. But at the same time, you're also able to affect a better outcome than you might just get with microneedling alone. But still, I'm not sure the data is really there to support it full bore yet.
I've kind of been a big fan of the RF micro for me. Again, different backgrounds. It's cool that I love this. Dr. Schlesinger, the first time I met you was at a multi-specialty conference. I love collaborating with so many people with different expertise, and obviously your knowledge of the skin is going to be vastly superior to mine. But again, I think more like a surgeon, which again, maybe that's not the best approach for acne scars. But that being said, the radio frequency devices, I've jumped into the InMode family. I like the depth of penetration. I like the fact that probably I'm in Chicago, you're in South Carolina, where I have a lot of patients from, I rarely have a Fitzpatrick 1 patient who's coming in. I have more on the, kind of more of multicultural ethnic pathway. So I really can't use many of the other laser devices for me. But that being said, it doesn't mean one device is better or worse. It's all about what have you tried and what experience have you used each device with. For the CO2 and have you tried ever cross TCA or pinpoint irradiation of any other techniques out there? For discrete scars like acne pick scars and stuff like that. Are you into that?
Yeah, so cross technique, we have tried that. I mean, I have used that. I think it's an older technique, developed 2002. It's been around for a while. And basically what you're doing is you're doing chemical reconstruction of skin scars. Is what cross means. In that technique, you're taking possibly, either 99% or 100% TCA on on a little toothpick, and you're treating just the center of your ice pick scar. We have done that. I like that for lighter skin patients and darker skin patients. You also have to be very diligent about wound care afterwards, because you can get hypopigmentation quite easily with that. So it's not a go-to. I'm aware of it. We've tried it. I'd much rather use a combination of punch excision followed by resurfacing if I'm going to be treating ice pick scars. Punch excising the scars and then resurfacing the whole field has worked well in my hands, and it gives you a little bit more of a. And I do understand that we also have a fair amount of skin of color, maybe not as big as a large percentage of our practice is yours, but in the 25% range for us. So we do have to balance that. So in skin of color patients, it might be punch excision and microneedling or RF, things like that, and in other patients it might be a combination of punch excision with laser. I just feel I get better control with a CO2 laser than I would with TCA cross.
Yeah, I think I've kind of moved on from cross TCA as well. I think one of the issues I've had with cross TCA, like you're talking about, is number one is control. You can't control your depth quite as accurately. You worry about spillage with the TCA going above and beyond the area that you're treating. But I think the concept of treating just the scar at a higher change than the other area is kind of like a targeted fractionated approach. So kind of that mind field, but you're targeting the mines that you want to treat. I love the concept of that, but I think again, it's a little bit of a higher risk, higher reward. I've dabbled in pinpoint irradiation, which is similar to cross TCA, where I've done the CO2 and I've gone stronger with the CO2 with like a discrete beam into the scars themselves, and then kind of fractionating over that. And that seems to be a little bit more controlled than that. But again, I think it's all semantics. They all kind of work in a similar way. You're using you're using the punch. I haven't used the punch as much, so help me understand that a little bit. So you're around each scar, use the punch. Do you suture it up? Do you remove the skin? Like what goes on with that approach? And then what do patients expect with that technique?
Yeah. So, I mean, my goal for punch is, if you look at the scar underneath the skin, it is going to have some sort of roots, to the scar underneath the skin. So you have to be careful not to use too small of a punch. If you punch out the scar to the center of the scar and leave the periphery of the scar present, then most likely that scar will recur. So you have to do a punch that's large enough, or a small excision that's large enough. Sometimes the elliptical punches are very helpful, and you've probably seen those. They were kind of the craze for a while. But using a punch like that and then bringing normal skin back to normal skin, and then helping those scars heal with silicone, topical silicone, to really get a nice outcome. Having suture removal, silicone therapy after, and then moving into the CO2 laser has worked quite nicely. I think that's a nice technique to use. The key is you have to get normal skin back to normal skin. So because if you punch it out too small, it'll most likely come back. You've got a recurrence of the scar. Another depression will form in the same area. So it's not foolproof. You punch out 10 scars, maybe 8 of them will do great and a couple of them won't. So sometimes you have to punch them again or treat those in other ways. So it's not foolproof, but it's very helpful.
You mentioned subcision earlier. Do you have a filler of choice? Do you use filler with subcision? Do you use them independently, and do you use filler for your scars too?
Yeah, so I think that's one of the newer things that's been talked about is so basically subcision, the way I look at it to explain it, is you're basically creating PRP. So when you subcise underneath the scar, you're breaking up the collagen fibrils that connect the dermis down to deeper tissue that's created, right? But if you go in there and you subcise, you're breaking that up, and you're breaking up, creating a pocket and filling the pocket with blood. So the pocket will fill with blood. You'll get some regenerative tissue, regeneration going on, and then you'll sort of fill that scar. Some swelling will occur, but over time that will settle. So, and then you'll end up with a scar, and maybe not as bad, but you'll end up with a similar, scar after time has passed. So the way to combat that is to introduce a filler into the scar. And also for a number of years, we're using hyaluronic acid and different things to treat. But of course, those are temporary and they don't really have the lifting and holding power of some of the more long-lasting fillers. So the PMMA, the methacrylate filler, has become the sort of filler of choice for my practice. And then one of the main reasons is it has an approval. So it's the only filler that's got an actual approval for acne scars. And there's, paper published that's 12-year, 12 months data on acne scars with 2 treatments. So that's been out there for a while. So, in my practice, I've been combining the combination of subcision plus Bellafill and then microneedling as well. Those 3 things together can be quite nice for acne scars. Microneedling treating the surface and treating the general, dermis and epidermis and sort of getting tissue remodeling going. The subcision followed immediately by placement of PMMA microsphere filler underneath the skin can help sort of lift that acne scar. So when you have that, when the blood goes away and all the swelling goes, you've got that support left behind with that collagen carrier PMMA filler. So that, is a nice option, but really it's best for treating rolling scars. It's not good for ice pick scars and it's not good for scars. You really want to treat that middle scar with it.
I think Bellafill is kind of underreported how great of a product it is for acne scars, because I think it's been transformative for me treating acne scars. It is an amazing product, Bellafill PMMA. It's got 2 components. It's PMMA plus the collagen. I don't think I've ever had better results than when I've treated patients with some sort of combination therapy with Bellafill, because usually it's one component, like you mentioned earlier, you're going to treat with Bellafill, and then the other components of the scar you may have to kind of break down and kind of use some sort of ablative or RF or needling a device to kind of work with that. Why doesn't everyone use Bellafill? Like, what are some of the drawbacks of Bellafill, and should everyone be using Bellafill, or do you think it should be sort of like limited to certain expert injectors?
I think the latter. I mean, I think the main thing about Bellafill you have to remember is it's a long-lasting product. I mean, we've got 5-year data for the nasolabial fold for this filler. So in essence, it's a long-lasting product, whether it's permanent or not. We don't say that, but the bottom line is it's going to be there for a while. So the main things we've learned over the years with Bellafill is quantity should be small. It's not a filler you want to bolus. It's a filler you want to nuance. And for acne scars, you're subsizing, whether you're using the included needle, 26 gauge 5/8 needle that comes in the package, or using a new core needle or some other thing, some other device to create subcision. It requires training. I think the Bellafill can be used by expert, filler practitioners, but they should get their hands on it, and they should, get some training with someone who's experienced with it, because there's a lot of nuances. It's very different than, it's not an HA filler. It's very different in the way it's much more viscous as far as the feel of it goes. The flow characteristics are much different than HA fillers or PMMA. I mean, or calcium hydroxylapatite or Sculptra or any of those other products. I mean, it doesn't push forward in the needle, so you can't antegrade that product. You can't inject it forward. It's always going to be injected when you're moving backward with the needle for the most part. For acne scars, you have to kind of create a little pocket for it. You want to undercorrect when you're treating with Bellafill. You want to plan on 2 treatments, so you can correct in layers with that product, and then you can go back 3 months later. I mean, the studies were done with 1 month between treatments in the 12 months data, but in reality I find that the collagen remodeling process takes longer. So there's a whole nother, we could talk for hours on just Bellafill alone, but the reality, from what you said, I feel like it is something that should be used by practitioners who are very comfortable already with using all of the other products on the market. And then they should most likely receive some training from someone who's experienced at using the product, because, it's not one you can reverse easily. So
For sure. And I think this product, I think it probably should be limited to, if you're going to get treated with Bellafill, I probably would encourage anyone listening to go to someone who is a very, very experienced injector. And I almost think that it's really nice if the injector has some sort of surgical training. And for you, for example, you have the Mohs, and you have you're used to doing surgery on the face. You're used to kind of working with that. So if you do run into a problem, A, you know how to handle it. And B, the other thing that's interesting with Bellafill is that you almost have to prep it like a surgery. Like it's not like normal HA where you prep it and prep the face. You almost have to, you have to assume that there is some sort of, there's bacteria on the skin no matter how many times you prep it. So you have to be treating this super sterilely. This is, I think, at least the way I inject it, it's almost like a sterile procedure.
Right. I agree with you 100%. I think that we've learned a lot from the original studies, because when the original 5-year study was done, it wasn't really made clear to the investigators how to prep the skin. So I think they saw a little bit more complications. They saw a little more bacterial infections, things like that occurred. Not a huge number. It's still very small, but could be better. So now it's, full HIPAA cleanse, scrub, clean as you go, clean that inject constantly, never, everything's sterile and, that we're touching. The patient is advised, come in with clean skin, no makeup, things like that. So we're doing exactly what you said. We're being as clean as we can. Now, I think the other thing you should remember with Bellafill, that our listeners should remember, is that again, it's not a fill you want a bolus. So you're using small quantities, linear threading, or small quantities deposited under acne scars. You're talking about 0.05 or 0.1 ml at the most per site, more on the smaller side. And then when the areas that can be a little bit higher risk for infections are more the cheeks, when we're treating the cheek area. That seems to be the area where I have seen, I was a trainer for that company for 3 solid years and had a lot of experience with different folks out there across the country. And what I saw was the area that was probably most likely to have, as far as infection, like abscess, would be the cheek area. And the other thing about Bellafill to remember is that where it's not to be used. It shouldn't be used underneath the eyes and periorbital tear troughs, probably not the best place. And then it's really contraindicated for lips. So anywhere we have that orbital muscle, that movement, is an area probably to stay away from with Bellafill. But it's very handy when it comes to treating nasolabial folds, for lifting in the lateral face. I use it a lot. And then on acne scars, it's really a winner. Like you had said, it's a hands down a very nice product to use. And I think once you've trained on it and learned how to use it, and I do agree with you, the surgical training is very helpful. Knowing the layers, knowing the planes, knowing your anatomy is key, and then knowing the nuance of how to inject that product in a safe way, and what to look for as far as complications, because it's not easy. I mean, you can probably work on dissolving and doing some of the things you would normally do if you had a intravascular event, which is very rare with Bellafill. I mean, I can't even think of it. I mean, it really didn't occur in the studies. So, but you should at least have some options.
Do you think the skin looks better after Bellafill? Like not from an acne scar perspective, but just better. I've had some patients tell me maybe it's the collagen component, but they feel like their skin just looks healthier after being injected with it. Have you noticed that? Observed that? Your thoughts?
Yeah, I think that's a way. I mean, I think that the thing about Bellafill is you're really creating almost normal collagen with Bellafill. If you look carefully under the microscope, you'll see the microspheres or whatnot, but you're creating collagen that's pretty close to normal, so you're really not creating scar tissue with that product, which is nice. And so therefore, it's I don't to my knowledge, it's not been studied, because with PLLA, with Sculptra, we've got some studies that show dermal thickness improving. So I think with Bellafill, that is something. So I think you're onto something there. As far as I know, I haven't seen any kind of data, showing increase in dermal thickness with it, but it would make sense from a skin quality standpoint. If we're building new collagen, then we should have increased skin quality.
I did not know that about Sculptra, but as an observation, a lot of my patients who use Sculptra, they just look better. Their skin looks healthier, but I guess that makes sense.
There's some data behind that.
Yeah. Cool. Okay, so with Bellafill, we kind of jumped in that, but that's not for everyone. Okay, so can you, if a patient comes in and says, I want to travel all the way to see you, Dr. Schlesinger, I want you to do 20 treatments on me at once. Will that work? Can you treat someone's acne scars with one treatment, or is it going to need a couple treatments, or is it patient by patient?
I'm sure it's very patient by patient. I always wary of that patient who comes in and says they want to have everything done at once. It always makes me a little nervous. I also want to be able to follow up on my patients. So I'm not really too thrilled about someone that says they're coming in from somewhere far and they're not going to be around. So I might defer that one and just maybe choose not to be the doctor for that patient. I want a patient who's going to, that will follow up, someone that will allow me to sort of design a plan for them that focuses on their needs. So you can't rush it. You can't rush that. You can't rush Bella. Even Bella is at least 2 treatments. Sometimes we're doing more. smaller amounts to sort of build those scars up instead of, you're not overcorrecting, but a little bit undercorrecting a little bit, and then having it build and building on top of that. And then of course, acne scarring, as we know from, a lot of publications in our experience, it's a combination therapy. It's a combination treatment condition. There's not one thing that treats, I believe, everybody, or nor can you blast them with, a lot at once.
Yeah, you're definitely worth traveling to see. It's just as long as the
Well,
patient's committed to seeing you for 3 or 4 treatments and willing to take that extra step to follow up with. But definitely, you're worth seeing.
I can say the same thing about you. I know you've got a fantastic practice, and the fact that you're doing all these great educational things, it's great. But just a general sense, the patient's going to be
committed.
Follow-up's key. Yeah.
Yeah. Okay. So that bit of it. Do you think there's any skincare products that work for acne scars? So is there any topical product you've seen that someone can put on their skin and it will get rid of acne scars, improve acne scars? What's your thought?
So no, I think the short answer is there's not one thing I would recommend that's really going to make a difference. In combination with things that we already do to sort of help the health of the skin, I would recommend the things that you might as well, looking for growth factors, looking for, things that I know will sort of help the collagen. But skincare products are very very surface oriented. We've got a little bit of penetration data for a few of them, a few of the topicals, but I think in combination to help skin quality, it's great. But can you prescribe a topical product that's going to really affect acne scars in a meaningful way? Not so sure I would hang my hat on that, at this time.
Yeah, it's something that patients should be concerned about their skin, of course, but will it get rid of their scars? And sometimes if you see an infomercial talking about removing acne scars, I'm like, oh my gosh, I would love to have the product. It's probably not going to work if it's Saturday morning or late night on a infomercial.
Yeah. Usually when I'm watching them.
Okay, so can you completely erase an acne scar? Can you make it so it's gone? If someone comes in and is like, I want my scars gone, I will do whatever it takes. Can you make my skin completely scar-free?
I always remember that adage to under promise and over deliver. So I think that's the thing to think about there. So do we have great results sometimes? I think we do. Can we guarantee that, or can we legislate that to happen? I think no. But I try to put together the best combination I can for the patient and tell them it's a partnership. So we're working together on it. We're doing this together. We're choosing our treatments together. We're working with their lifestyle, their scars, their goals. But there's no perfect in medicine. So I would say the broad answer would be no. But sometimes you hit a home run.
It's improvement. I have not been able to erase anything, but it's about improvement and saying, hey, guess what? I feel more confident. And I think of things sometimes in terms of a radius, that maybe you can see your scars from 12 feet away. And then maybe after the first treatment, it might be 8 feet away and then 6 feet away. But if you're looking to look in that big mirror and look to see if you can see a scar, that's a really hard test, I think, for, especially for a really deep pronounced scar. That's
right. And people tend to do that, and that's completely understandable. If you have one thing done on your face, you're going to be scrutinizing, and that's, it's hard. I mean, that, we have to, be grateful for what we have. And I think, be grateful for improvements that we can get, go, like you said, go to experienced practitioners, do the best thing you can. But, in the end, we are just looking for improvement.
Perfect. Okay. So if you had one thing, the biggest thing you had to explain to a patient about acne scars that you wish they knew beforehand, is there like one piece of knowledge you wish that every acne scar patient knew before they saw you? It's like, okay, before I come in, I wish they already knew this.
If I could roll it back to the prevention piece, it's more like, how could we prevent them? So, when you have acne, get it treated. I wish I could tell people when they're younger that not to let their acne go. So I try to do a very good job of treating my patients, from the medical practice of treating their acne, and try to prevent that inflammation. Because once inflammation set in, the scarring is set in, now you're dealing with that problem, which is a little bit harder to deal with. I think nothing specific I can think of. It's really just all about prevention. As far as when you already have the scars in place, I think go to someone experienced. I think that's the key. I do see a number of patients, I'm sure you do as well, that, go from place to place, and, and they may not be selecting the practitioner that's best for them at the outset. So I think it's important to listen, ask questions of the physician you're going to see, you know, and go to someone who's got the experience that does it all the time.
Yeah, I think that just hearing you talk, you can tell that you are, I mean, besides reading all your studies, and you can tell that you're so well versed and understand this on such a deeper level that why would you go to someone who doesn't have that that background? And so for me, it's like, if you're going to choose someone, choose someone who's passionate about that, who's focused on that, who can treat you on multiple levels. I'm not going to bash any other levels of providers, but for something like Belafil, I would definitely encourage providers for patients to go to someone with experience. If you're going to go to someone with acne scar, you need to have a lot of tools in your belt, and that's my take on it. Because sometimes I see so many patients, I'm not sure if you do, but so many patients who go to less experienced providers, and some maybe not up to standard of care stuff is being practiced.
Right. I mean, and it's so common because some of the things we use have been commoditized quite a bit. So they're in the hands of a lot of people. So, and again, I agree with you. And, I mean, I want everyone to do a great job. I want any practitioner that's going to pick up a syringe of Botox or a filler or anything like that to do an excellent job. And we're well trained, and we all have to do what we're comfortable doing. I advise, patients not to do something they're not comfortable with. I advise practitioners as well not to do something they're not comfortable with. I mean, use that sort of your sixth sense, maybe your spidey sense, or whatever you call it, your sixth sense, that if you're not comfortable, don't treat. And that's key.
So I have a non-related question. So your photo, you have like the cleanest cut hair. Now, when I saw you, you had like a matching ponytail. I was looking forward to seeing this. There's only like 2 or 3 people who had ponytails. I was like, now that's a guy I know that I want to talk to. So
well, if you turn the recording off, I'm more than happy to show you.
That's okay. We'll do that.
But I don't mind. I mean, I've been in all the meetings and everything. I have a ponytail. I think after the pandemic, I just I started growing it, and I'm like, okay, I'm just gonna let it roll, see how it goes, and it's just I just never changed it, and I've now gone to a lot of meetings and seen a lot of people, and they're getting used to it.
When are I've had this debate. We'll see who's going to cut. When are you ever going to cut your ponytail? Is it going to be one of those kind of I'm getting sick of it, or it's a hot South Carolina day, or is it sort of who knows?
Who knows? I don't have any plans yet to. I actually had a patient ask me that today who was doing filler on, asked me about it. I said, you know what? I really don't know. I'm grateful for every single day that I wake up on this earth, and I'm going to just enjoy each one day by day.
Love it. Love it. Well, I thank you so much for joining me on a late Monday night. I mean, you are such a wealth of knowledge to me. I mean, I learned so much from just talking to you, and keep doing what you do to bring all of us up, bring all of our games up to with everything in every area of cosmetic and aesthetic surgery.
The same, and thank you for providing this important service to our patients. And it's you can't say enough about how important it is to get the word out, and for us to have these kind of conversations so people can really hear. So thank you for that service.
Cool. Thanks so much.